Welcome to The Explainer. Today we are diving straight into a rapid-fire clinical surgery board review, packed with high-yield case studies and those absolutely crucial exam pearls. Let's get right into it. Question 31.
Question 31. Which of the following conditions is identified as the leading cause of secondary liver dysfunction and progressive organ failure within a specialized surgical intensive care unit? A. Multi-organ dysfunction syndrome, B. Echinococcal hydatid cyst disease, C. Acute halothene toxicity, D. Chronic viral hepatitis infection, E. Primary biliary cholangitis. The correct answer here is A. Multi-organ dysfunction syndrome.
So why is this the case? Well, MODS is a really severe complication that we see in critically ill surgical patients right after a major physiological insult. Think severe trauma, extensive burns, acute pancreatitis, or septic shock. It literally leads to progressive, sequential failure of organs that weren't even initially involved in the primary injury. For your exam pearls, you need to remember the target organs. The lungs and the liver are the two most commonly affected organs in MODS. In fact, they're compromised in up to 70% of cases, and that's followed closely by the kidneys and the gastrointestinal tract.
Question 32. Which of the following neoplasms is characterized as the most common malignancy associated with HIV/AIDS, classically presenting as red-brown skin plaques that progress to nodular, ulcerated lesions? A. Invasive cervical carcinoma. B. Burkitt lymphoma. C. Primary CNS lymphoma. D. Squamous cell carcinoma of the lung. E. Kaposi sarcoma. Option E, Kaposi sarcoma, is the correct answer.
Kaposi sarcoma is an AIDS-defining malignancy, and it's actually caused by human herpes virus 8, or HGV8. It stands as the absolute most common tumor encountered in the HIV-positive demographic, primarily affecting the skin and the mucosal membranes. When we look at age-defining malignancies for your exams, keep this breakdown in mind. Kaposi sarcoma, driven by HGV8, presents as those indurated red-brown skin plaques, and the first-line management for localized lesions often uses local radiotherapy. Then you've got Burkitt lymphoma and primary CNS lymphoma, both of which are strongly associated with the Epstein-Barr virus. And finally, cervical carcinoma, which is driven by high-risk strains of the human papillomavirus.
Question 33. Which of the following body fluids is most commonly implicated in the sexual transmission of HIV? A. Saliva, B. Tears, C. Semen, D. Urine, E. None of the above. Making C. Semen the right choice.
Understanding viral loads is absolutely crucial here. HIV is transmitted via specific body fluids that contain high viral loads. Those include blood, semen, vaginal secretions, and breast milk. Now, you might be wondering about saliva. Saliva actually contains endogenous secretory factors that actively inhibit HIV, which makes human bites an extremely rare route of transmission. So, for your high-risk infectious fluids, remember blood, semen, vaginal and cervical secretions, and breast milk. On the flip side, your non-infectious or low-risk fluids, unless they're grossly bloody of course, include saliva, tears, urine, sweat, and feces.
Question 34. A 47-year-old male underwent a right inguinal hernia repair with a lightweight mesh herniaplasty. 5 days later, he presents with a high-grade fever and a heavy volume of clear, purulent discharge from the surgical wound site. What is the most appropriate definitive management for this patient? A. Open the skin stitches, perform a bedside wash with normal saline, and leave the wound open. B. Open the skin stitches, wash with normal saline, and perform immediate primary reclosure. C. Surgical exploration of the wound, thorough debridement/wash, and complete removal of the mesh. D. Initiate high-dose intravenous antibiotics alone without wound manipulation. E. Open the skin wound, insert a Silastic closed suction drain, and reapproximate the skin immediately. The correct answer is C. Surgical exploration of the wound, thorough debridement and wash, and complete removal of the mesh.
The reason here is that the presence of purulent discharge tracking all the way down to a prosthetic implant signifies a deep organ space mesh infection. This turns the situation into a Class 4 dirty scenario. Because bacteria form a tough, protective biofilm over synthetic prosthetic material, infected meshes typically require complete surgical removal to actually achieve resolution. For exam pearls regarding mesh vulnerability, remember that infection is way more common with traditional heavyweight, dense meshes compared to modern, lightweight designs. And as for salvage exceptions, in rare, highly selective superficial contaminations, an implant might be salvaged using meticulous surgical debridement, targeted culture-specific IV antibiotics, and negative pressure wound therapy.
Question 35. Which of the following combinations correctly identifies the optimal method and timing for preoperative surgical site hair removal? A. 1 day before surgery using an electric hair clipper. B. The night before surgery using an electric hair clipper.
C. In the operating theater immediately before surgery using an electric hair clipper. D. In the operating theater immediately before surgery using a chemical depilatory cream. E. 1 day before surgery using a chemical depilatory cream, making C the correct choice.
Hair removal should really only be done if strictly necessary, and it must be performed immediately prior to surgery in the operating theater using an electric hair clipper. If you shave hair the night before, it creates these microscopic skin nicks that allow for bacterial colonization, which literally doubles the post-operative surgical site infection rate. For the exam, know that razor blades are strongly discouraged because those razor-induced microabrasions act as direct entry points for bacterial multiplication. And depilatory creams? Although they are associated with low infection rates, they're super messy, carry risks of hypersensitivity dermatitis, and honestly, they're just far less practical than clipping.
Question 36. To ensure optimal tissue concentrations, what is the best timing for the administration of standard preoperative prophylactic antibiotics? A. 24 hours before the surgical incision. B. 4 hours before the surgical incision. C. 2 hours before the surgical incision. D. Within 1 hour before the surgical incision. E. Immediately following the first skin incision. Option D is correct.
Systemic prophylactic antibiotics absolutely must be administered within 1 hour or 60 minutes prior to the skin incision, or at the exact time of anesthesia induction. This ensures that peak bactericidal drug levels are actively present in the tissue at the very moment the barrier is breached. Now, for prolonged procedures, antibiotic doses have to be repeated intraoperatively if the surgery outlasts 2 half-lives of the drug, or if blood loss exceeds 1,500 milliliters. And regarding the WHO surgical safety checklist, the timeout phase explicitly mandates a verbal confirmation that antibiotic prophylaxis was administered within the preceding 60 minutes before cutting.
Question 37. A 42-year-old male undergoes surgical repair for a traumatic perforation of the ascending colon. On postoperative day 6, he develops a swinging pyrexia, leukocytosis, and localized abdominal tenderness. An ultrasound confirms a localized fluid collection consistent with an intra-abdominal abscess. Which of the following organisms is most frequently responsible for this presentation? A. Bacteroides fragilis. B. Pseudomonas aeruginosa. C. Staphylococcus aureus. D. Streptococcus pneumoniae. E. Shigella species. The correct choice is A. Bacteroides fragilis. The baseline endogenous microflora of the large bowel is predominantly anaerobic, and it's heavily dominated by Bacteroides fragilis. So, following a colonic perforation or fecal spillage, Bacteroides fragilis is the primary organism you'll isolate from localized intra-abdominal abscesses. Note the abscess synergism here. It's a great exam pearl. While E. coli frequently drives the initial early bacteremia and acute peritonitis phase, it's Bacteroides fragilis that acts as the principal driver behind late-stage localized intra-abdominal abscess encapsulation.
Question 38. A 65-year-old man undergoes a low anterior resection for rectal cancer. On postoperative day 5, his parameters reveal a temperature of 39 degrees Celsius, blood pressure of 150 over 90 millimeters mercury, pulse of 110 beats per minute, and a respiratory rate of 28 breaths per minute. A CT scan of the abdomen reveals a localized pelvic abscess. Which of the following terms most accurately defines his condition? A. Systemic inflammatory response syndrome. B. Sepsis. C. Severe sepsis. D. Septic shock. E. Multiple organ dysfunction syndrome. The correct answer is B. Sepsis.
This patient perfectly matches the clinical criteria for sepsis. He meets more than 2 SIRS criteria. Specifically, his temperature is over 38 Celsius, his heart rate is over 90, and his respiratory rate is over 20. And he has a radiologically confirmed source of infection, which is the pelvic abscess. So let's review the sepsis diagnostic criteria continuum. SIRS requires 2 or more of the following: temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute or PaCO2 less than 32 mmHg, and a WBC count greater than 12,000, less than 4,000, or greater than 10% immature bands. Sepsis is simply SIRS plus a confirmed or highly suspected source of infection. Severe sepsis is sepsis complicated by acute organ dysfunction or tissue hyperperfusion. Finally, septic shock is sepsis with persistent refractory hypotension despite aggressive fluid resuscitation.
Question 39. A clear hemoserous discharge is observed leaking from a single localized point, less than or equal to 2 centimeters, of an appendectomy wound on postoperative day 3. What is the grade of this wound according to the Southampton scoring system? A. Grade 2. B. Grade 3A. C. Grade 3B. D. Grade 3C. E. Grade 3D. Making B, Grade 3A, the correct answer.
The presence of clear or hemoserous, which means serosanguinous wound discharge, automatically places the infection under Grade 3 of the Southampton system. Because the discharge is strictly confined to a single localized point measuring less than or equal to 2 centimeters, it is classified specifically as Grade 3E. Here's the full Grade 3 breakdown for your exams. Grade 3E is clear or hemoserous discharge at one point only, less than or equal to 2 centimeters. Grade 3B is discharge tracking along the wound line greater than 2 centimeters. Grade 3C is a large volume profuse discharge, and Grade 3AD is a prolonged clear discharge lasting greater than 3 days.
Question 40. A 39-year-old male who underwent an open appendicectomy for a perforated appendix presents on postoperative day 4 with a swollen, erythematous wound draining frank pus. What is the most appropriate management strategy? A. Prescribe empirical oral antibiotics and manage on an outpatient basis. B. Admit the patient, remove the skin sutures to open the wound, obtain a pus swab for culture, wash thoroughly with normal saline, and leave the wound open. C. Put the patient on empirical intravenous antibiotics while keeping the skin edges closed. D. Open the skin sutures, wash with saline, and perform immediate primary resuturing. E. Apply a compression dressing and re-examine in 48 hours. Option B is the correct management strategy. Admit the patient, remove the skin sutures to open the wound, obtain a pus swab for culture, wash thoroughly with normal saline, and leave the wound open.
An incisional surgical site infection with active pus collection requires prompt source control. The skin sutures must be removed to open the wound, allow drainage, and obtain those crucial cultures. The wound has to be washed out and left open to heal by secondary intention or delayed primary closure to avoid trapping bacteria inside. For complicated appendectomies, perforated or gangrenous wounds have a really high infection rate, about 13 to 20% without prophylaxis, so postoperative therapeutic broad-spectrum coverage should be maintained for 4 to 7 days. The exact source control sequence you need to memorize is Step 1, open, Step 2, culture, Step 3, debride and wash, and Step 4, pack and leave open. So, as we wrap up this rapid-fire explainer, ask yourself, how will mastering these exact clinical sequences define your very next surgical outcome?